Can you guys hear me okay? Am I coming out on the microphone? Yeah? Great. A little bit louder. All right. So I got told off yesterday for speaking too fast, but given I'm the last person, I feel like I'm going to have to slightly. So let me know if you're not understanding me. So when Nick asked me to do this, we actually sit next to each other, so I didn't really have much of a choice, did I, Nick? But when he asked me to do this, I did think, oh my God, I don't think there is enough information about what patients know about testing in the UK. So I guess the message, I'm going to start with the overall message of my talk is, I think we need more information on this. It is my overarching message of the whole presentation. I'm going to let you guys change the slides, that's all right. So next slide, please. So we've kind of covered why do patients need to understand testing already, and you've heard a lot from the clinical community about how it can be for peace of mind, how it can help them understand their journey in terms of what treatments they are going to work best for them. And I just wanted to point out very briefly that we've heard a lot about, I mean, Brian kind of disagrees with me on this, but in my opinion, not everybody wants to know everything at the point of diagnosis, and I just wanted to make sure that was in my presentation because I have heard that from patients. But we also can't forget that tests are essential to getting them the best care. So it's like a weird balance of what do I need to know right now versus how am I going to make sure I get the best care if I don't know this. So I guess that's where we're at in terms of what we've heard so far. Next slide, please. Can you just click through one more time? But in the UK, we have quite a strange situation at the moment where we have the European Medicines Agency, and I said I'd get Brexit into my talk. I don't know how that's going to change following Brexit, but currently they tell us, yes, a drug is safe to use, and then we have bodies that are technically independent to our health service, but provide recommendations about whether a drug is better than the current standard of care and whether it's cost effective. And there's kind of been a trend with the last couple of novel therapies for CLL to move towards only approving them for use, so reimbursed on the NHS, for patients. So this is the recommendation for venetoclax and rituximab, and you can't probably read it very well, but basically you can only have it at first relapse if you can't have ibrutinib for other reasons and you're 17p deleted, or if you don't have a 17p deleted or TP53 mutation, you can only have it after ibrutinib. So clearly, you need to be tested for these mutations to work out where in the pathway you're going to be able to have these drugs. One more, please. And it's the same for ibrutinib at the moment. So you can only have ibrutinib first line if you're 17p deleted or have a TP53 mutation. So clearly it's really important in the UK to get these tests. And Nick's asked me to speak about whether or not patients are getting these tests and whether they understand the consequences of them. So if we could go to the next slide. And then he talked about himself. And he's just, I hope Nick doesn't mind me talking about this a little bit, we have talked about it, but he's just moved from Wales to England in terms of his healthcare provision, and he's getting tests that are not routinely available in Wales. So there is a disparity there, and it's something we'd quite like to address in the UK at some point, but there's just one example there is a disparity. And I have actually spoken to a couple of other people recently. There was one lady who didn't understand why her genetics meant she couldn't have ibrutinib, so she knew she wasn't 17p deleted or TP53 mutated, but she still wanted ibrutinib, but she didn't understand the NHS system and why NICE had said she can't have it. And then there was also another gentleman who had the TP53 test. He wasn't even at the point of treatment, but he was still wondering why NICE had only said that it was only available to him and not to others. So he was concerned about the wider society. So patients are thinking about this in the UK, and there are clearly a little bit of confusion about the role of testing in the UK patient population. Next slide, please. There's also the issue that not everyone gets specialist care, and Jennifer covered this a lot in the US perspective, but it is still an issue in the UK that not everybody gets to see a CLL specialist. We still have general haematologists, so that's another issue. But I still feel we are lacking in evidence about what patients really know about the role of testing. So next slide, please. So what do we know? So I've taken what Leukemia Care knows rather than, I apologise to UK colleagues if you have a bit more information about this, but what sort of treatment options are patients in favour of? So this is 2017 data from our Living with Leukemia survey that we run. I believe it's about 1,452 of the respondents were CLL patients. So what are patients in favour of? They would like a choice. I just wanted to put that in there. That's really important to patients. Next slide, please. Oh, they would prefer an oral medication to an IV medication, and we could speculate about reasons for that, but that's not the point of my talk. It's quite clear there, although there is still a lot of people in favour of intravenous, but I think that might be just what traditional CLL treatments have been. Next slide, please. Now this one's interesting. Would you consider it positive if a treatment plan contained a treatment-free period or included stopping treatment altogether? And actually, a lot of patients are in favour of that. So, next slide, please. My overall feeling about this data, and this is what my poster is about if you want more information about this, is that patients seem to be moving towards, in terms of their preferences, the newer novel therapies that are available. And you might say that's not surprising, but personally I find that quite surprising because they do still come with side effects. There are still downsides to these therapies, but overwhelmingly they are in favour of them. In the same survey, however, we did ask, have you had tests for the chromosome abnormalities? So have they even been tested for the things that would stop them get these new treatments if they didn't know? And overwhelmingly they said no. Now, I was thinking a bit about why this might be, and you could look at this negatively straight away and go, oh my God, there's a massive access issue in the UK. Or we could look at this in, do they not understand the question? Do they know what we mean by chromosome abnormalities? Do they know what we mean by mutation changes? That could be a factor. Are they genuinely not being tested? Do they not have access? Or are they all at a point where they don't need testing? And that's why they've answered no. And actually, I can't remember the exact percentage, but a lot of the people we spoke to were in the watch and wait period, so that is a factor. And I didn't want to turn this into a lesson on evidence-based advocacy, but I think it's really important when you're asking people, patients in particular, because obviously they're not scientists, the vast majority of them, or clinicians, when you're asking them questions like this, you need to know a little bit more about what the patients already know to understand their answer. So I'm trying not to draw too many conclusions from this, but I think from the anecdotes there are some access issues, but from this there might also be some understanding issues that need to be addressed. Next slide, please. And I wanted to bring in a bit about MRD testing. So we haven't actually heard from anyone, if I remember rightly, if I was listening, about MRD testing. But we have heard about the difference between Sanger sequencing and next-generation sequencing. So just briefly, if you don't know what MRD stands for, it stands for minimal or measurable residual disease, depending on what terminology you prefer. But it's essentially becoming a way in clinical trials, particularly in CAR-T, I believe, in the last couple of conferences I've been to, a way of measuring how someone is doing after treatment, because it measures how much CLL is left in your body post-treatment. The problem is there's no actual set standard way of measuring measurable residual disease. So some people use flow cytometry, which is not very sensitive, and in other places you can have it done by next generation sequencing, which we've already heard today is more sensitive. However, what do patients know about MRD testing? And I actually did a focus group, which is the subject of my poster outside that I'm going to present at IWCLL. And one person said, in answer to what would you define as a cure in CLL, staying in MRD negative, I suppose, or some words to that effect. And if people are using these concepts, these tests, as the way they're defining cure, but if they're told they're MRD negative and then relapse because they haven't been tested at a sensitive enough level, that's going to be quite distressing for someone. So I think it's really important to also make sure people understand methodology around testing as well. It may not seem important to patients, but I think this illustrates that it, excuse me, I should have got some water, illustrates that it is still quite important for patients to understand this. Next slide, please. Oh, thank you so much. That's better. So as takeaway messages, I wanted to just point out what we as an organisation in the UK are doing at the moment to try and help patients understand testing. So we have what we call advocacy toolkits, and these are different to our patient booklets, but they go into more in-depth information on a very specific subject. So we can balance that I'm not sure I need to know yet with I do want to know, and patients, when they're ready, can access various bits of information. I think what we need to do is actually collect more data on this, and that's a whole other talk that my colleague Zach is very, very good at, talking about why we need evidence and why we need all this to back up our advocacy efforts. When I say provide an advocacy service, I don't mean set up like a whole organisation dedicated to helping people navigate the healthcare system, because in Leukemia Care it's just me. So I don't know if describing me as a service is a great way, but having someone in your organisation that can answer those questions, it sounds simple, it sounds obvious, but I find it really, really, it's new to Leukemia Care, and it has been super popular. So someone who can just sit down with a patient and say, this is how the healthcare system works, and yes, I agree with you that it's not always fair, but if you can help them understand how it currently works, it does help allay some of those fears. And obviously there's the aspect of campaigning for better access to specialist knowledge and testing, but that's sort of beyond the realms of this talk. So I hope that's given you a bit of an overview of what Leukemia Care are doing in this area, what we know, and a bit of an admittance that I probably don't know as much as I should about what CLL patients know about testing, and I think Nick's given me an idea for my next research project.